couple of frameworks just as you're starting to try and sort of generate a prognosis in your head for these folks. One of them is one we created. I really like Venn diagrams, as it turns out. So here's another Venn diagram with circles. That there are different factors that we need to consider when we're looking at prognosis. One of those are things that are present prior to the event. You've got somebody in pain coming in. You're trying to estimate whether they're likely to develop a chronic problem. In terms of things present prior to the event, what might be some interesting things that you'd like to know about? What do you think? High blood pressure? What might high blood pressure be an indicator of? Possibly a vertebral artery problem. Possibly. If somebody's got high blood pressure, I know this is a bit of a blanket statement, but maybe that indicates some kind of a general health status, perhaps. Maybe their physical activity levels, something like that. So it may be sort of an indicator of other things. So yep, that would work. Anything else that you might be thinking about? What were you like before the accident? Anything there that might make a little sort of red or yellow flag go up in your head? Previous injuries? And if they did say they had a previous injury, what would you want to know about that? If it ever went away, yeah, sure. What was that like? Did it recover well? Did you have persisting problems with it, right? Absolutely. You're starting to get into their own expectations now, right? What happened last time? What do you think is going to happen this time? Sure, definitely. Anything else you want to know about their pre-injury health status or previous status?
Sure. Smokers or diabetes? Anything
Smokers, diabetic, diabetes, I should say. Yeah, so those things could certainly affect tissue healing, we think, right? I will say the evidence actually is not terribly strong, interestingly, for those, but theoretically it makes sense. So, by all means. We may also talk about pre-existing psychopathology, perhaps, any other chronic pain or pain conditions prior to the injury. We talked about physical activity. Physical activity is sort of an interesting one. That one I think can kind of cut both ways, right? People who are really sedentary, maybe you think their tissues aren't quite as resilient to sudden jerks and stretches and whatnot. Maybe they don't have quite as nice a capillary to fiber ratio, so it takes a while for their inflammation to go away. There's those sorts of things. Maybe they don't heal quite as quickly. On the flip side of that, though, the super active folks probably have their own sort of challenges involved. One of them is that their treatment outcomes, like their goals, would be much higher. So it might take a little longer to get there. There's another one I remember a study now, it was maybe 5-6 years ago, where they asked people who were like elite marathon runners to stop exercising for 2 weeks. Within 2 weeks, 30% of them developed depressive symptoms. So there's, I would say, either ends of that scale actually or either ends of that continuum are probably not great. I think I like sort of where I am. Occasionally active, mostly watching a lot of TV. I don't need a whole lot of the life. That's probably pretty good. And then of course there's reactions to the injury, right? And that's what we're looking at. So internal reactions, we've got the tissue levels, so there would be looking at sort of how the tissue was damaged, what type of tissue was damaged, the magnitude of the inflammatory response, all these sorts of things that really we can't assess all that well clinically. The mental level, we might look at sort of how distressed they were by the accident, by the injury, what they generally think about pain and injury, what they expect, all that sort of thing. So we might measure those things. And then finally, there's the external influences. And it turns out these are probably fairly important. Does this person live in a highly sort of litigious, highly medical legalized environment where you kind of have to prove you're ill all the time, right? It probably has an effect on whether or not they're going to recover smoothly. What's their social support like? Talking about either ends of a continuum, if you were to imagine where it would be best to have a spouse on the overly solicitous to overly punitive stage, so the, oh, don't do anything, let me help you with everything, to the, oh, stop your whining, get up and do anything, where do you think would be the best place to have a partner? Somewhere in the middle, that's right. So for those of you who are searching for a spouse or a significant other, you're looking straight up the middle there. You want to find someone who's not overly active, but not completely sedentary, not overly solicitous, not overly punitive. Right up there. All right, so you can think about some of those things. Here's another continuum. Apparently the thing I like second to Venn diagrams are continua. I believe continua is the plural for continuum. Is that correct? Here's a continuum of prognosis, from unfavorable to favorable, so from bad to good. When it comes to guiding your clinical treatment decisions, when it comes to knowing what type of action to take, where do you think is the worst place to be on this continuum? What do you think? So that part's certainly not good for the patient's perspective, but I would think it might give you a bit of a sense that you need to do something early and quick, right? Maybe multimodal care, you need to really address this. This is good. Over here, you have a sense of perhaps what's going on. Where's the worst place to be? From a clinical decision-making standpoint. Right in the center. Yeah, absolutely. Because right in the center, you really don't know. Right? I mean, flip a coin. It might get better, it might not. Do I need to treat you? I don't know. Maybe, maybe not. So really, this is pretty well the worst place to be. And yet, as I just said, roughly 50%, somewhere 30 to 50% of people say following a whiplash injury are at about 50-50 chance of recovery. So what I hope we're going to do, as you start to do a prognosis-based assessment of your people in pain, you'd ideally like to start moving towards one of those two poles. Of course, it would be great for you as a clinician and for the patient if you're moving in this direction. But you still need to make sure, even if you're heading in this direction, every assessment you do, every question you ask, should be moving you towards one of those two poles. Right? So you think about that, and then you could even start to sort of, group these things a little bit. There's going to be a sort of a broad group of people in that moderate risk category, which are still a little bit of, I'm not sure. I won't know right off the bat. I'll probably know after a week or two. That's probably where those folks lie. And then you're going to have a few people in the high risk category and a few people in the very low risk category. And so those are the ones you kind of almost want to be able to identify early on.